Good morning, everyone. I'm Dr. Asim Hussein, and I'm delighted to welcome you today. Today, we'll be exploring tubulointerstitial nephritis, or TIN for short. This is the first slide of our presentation, and I just want to give you a quick overview of what we'll cover. We'll look into what TIN is, its causes, clinical features, diagnosis, and management strategies. So, let's get started and dive into this important topic together. All right, let's look at this case. We have a 58-year-old man who develops acute kidney injury, or AKI, about 10 days after starting amoxicillin, clavulanate. Now, this timing is important because it suggests a drug-related cause. He also has fever, a maculopapular rash, and eosinophilia, which are key clues pointing toward an allergic reaction. When we examine his urinalysis, it shows sterile pyuria, meaning white blood cells are present without bacteria. Putting all these pieces together, the recent drug exposure, the allergic symptoms, eosinophilia, and sterile pyuria, these features strongly suggest a hypersensitivity reaction affecting the kidneys. This points us toward a diagnosis of acute interstitial nephritis. Understanding this condition is crucial because it highlights how certain drugs, like antibiotics, can cause immune-mediated kidney injury. Recognizing these signs early can help us prevent further renal damage and adjust treatment accordingly. So, in this scenario, the most likely diagnosis is acute interstitial nephritis. The correct answer here is B now. Let's delve into why that's the case. The classic triad we see, fever, rash, and eosinophilia, after drug exposure is a strong indicator of acute interstitial nephritis. This pattern, especially when it appears together, really points toward this diagnosis. It's important to recognize these signs early because they can guide us toward the right management. Remember, in cases like this, the history of recent drug exposure combined with these clinical features is key to making an accurate diagnosis. This fits into our overall theme of recognizing drug-induced renal conditions promptly for better patient outcomes. All right, let's take a look at this question. We're asked to choose the best answer from these options: ACE inhibitors, loop diuretics, proton pump inhibitors, calcium channel blockers, and beta blockers. The scenario here is that we suspect drug-induced acute interstitial nephritis, or AIN. Now, the key point is identifying which of these drugs is most commonly implicated in causing AIN. From what we know, certain medications are more notorious for triggering this kind of kidney reaction. Specifically, among these options, ACE inhibitors are actually less commonly associated with AIN compared to others. Loop diuretics and calcium channel blockers are also less frequently linked. Proton pump inhibitors, however, have been increasingly recognized as a common culprit in drug-induced AIN. And that brings us to the most important concept here. Identifying the drugs most often responsible for AIN is crucial for diagnosis and management. When suspecting drug-induced AIN, knowing which medications are high on the list helps guide us to ask the right questions and consider appropriate tests. So, to answer this question correctly, the most implicated drug in drug-induced AIN among these options is the proton pump inhibitor. Correct answer is C now. Let's talk about why that's the case. Proton pump inhibitors, or PPIs, have really become one of the most common causes of drug-induced acute interstitial nephritis, or AIN. What's particularly important to note is that the presentation can often be delayed, meaning symptoms might not show up immediately after starting the medication. This delayed onset can make diagnosis tricky, so it's essential to keep PPI use in mind when evaluating a patient with unexplained kidney issues. Remember, understanding these associations helps us identify the cause more accurately and manage the patient's condition effectively. All right, let's take a closer look at this question. We're asked to identify the urinary finding that best supports a diagnosis of acute interstitial nephritis, or AIN. When reviewing urinalysis in suspected AIN, certain findings can really point us in the right direction. Now, among the options, dysmorphic red cells are often associated with glomerular bleeding, but they aren't the most characteristic for AIN. Heavy proteinuria suggests significant protein loss, which is more typical of glomerular diseases. White cell casts are a key clue. They indicate inflammation within the renal tubules, which is very consistent with AIN. Red cell casts are usually seen in glomerulonephritis, which involves glomerular injury, so that's less typical for AIN. Oval fat bodies are more common in nephrotic syndromes, where there's significant lipoduria. Therefore, the urinary finding that most strongly supports AIN is the presence of white cell casts, as they reflect the interstitial inflammation and infiltration characteristic of this condition. Remember, identifying these casts can help us confirm the diagnosis and guide our management effectively. Let's look at why the correct answer here is C. White cell casts and sterile pyuria are key indicators of interstitial inflammation, which is typical of acute interstitial nephritis, or AIN. When we see white cell casts in the urine, it suggests that there's inflammation happening within the kidney's interstitial space. Sterile pyuria, meaning white blood cells are present in the urine without bacteria, further supports this diagnosis. These findings are critical because they help differentiate AIN from other causes of kidney injury, guiding us toward the right diagnosis and management. Remember, recognizing these signs can really make a difference in how we approach treatment for our patients. Let's examine this question about urine microscopy showing eosinophils. The key here is understanding what the presence of eosinophils in the urine actually indicates. Option A suggests that urine eosinophils are diagnostic of acute interstitial nephritis, or AIN. While eosinophils are common in AIN, their presence alone isn't enough to make a definitive diagnosis. Option B claims that urine eosinophils are highly sensitive, meaning they appear in most cases of AIN. However, this isn't entirely accurate because eosinophils can sometimes be absent even when AIN is present. Option C states that eosinophils exclude glomerulonephritis, or GN. But this isn't correct, because eosinophils don't necessarily rule out GN. They're more specific to certain types of kidney injury. Option D says that the presence of eosinophils supports, but does not confirm, AIN. This reflects the reality that while eosinophils are a helpful clue, they are not definitive on their own. And finally, Option E claims eosinophils are seen only in parasitic infections, which is not true in this context. So the most accurate statement here is D. The presence of eosinophils in urine supports the possibility of AIN, but doesn't confirm it outright. This nuance is important because it reminds us to consider the entire clinical picture rather than relying solely on urine microscopy. The correct answer here is D now. Let's talk through the reasoning behind that. Urine eosinophils are interesting because, while they can be present in certain kidney conditions, they are actually neither very sensitive nor very specific for diagnosis. That means their presence alone isn't enough to confirm a particular condition. However, they can still be helpful when you interpret them in the right clinical context. So, if a patient's symptoms and other findings suggest a certain diagnosis, the presence of eosinophils in the urine can support that suspicion. It's all about integrating this piece of evidence with the bigger clinical picture. This highlights an important theme in nephrology. No single test is definitive on its own, but rather, we piece together multiple clues to arrive at the correct diagnosis. All right, let's look at this scenario. When AKI persists despite stopping the suspected drug, the question is, when should we consider a renal biopsy? The options here are: A, if the diagnosis is uncertain or there's no improvement after drug withdrawal; B, only if hematuria is present; C, immediately in all cases; D, never needed; or E, only in chronic kidney disease. The key point is that if a patient's kidney function doesn't improve after we've taken out the offending agent, we need more information. Often, a renal biopsy becomes crucial to understand what's going on at the tissue level. It's not always necessary right away in every case, so immediate biopsy isn't the default. Instead, we reserve it for situations where the diagnosis remains unclear or the patient isn't improving, which corresponds to option A. This approach helps us make more informed treatment decisions and ensures we're not missing other underlying pathologies. Remember, the decision to biopsy should be tailored based on the clinical context and whether the diagnosis remains uncertain after initial management. The correct answer here is A when we're trying to diagnose acute interstitial nephritis, or AIN. A biopsy can be really helpful. It confirms the diagnosis, especially in cases where the clinical picture isn't clear or if the patient's kidney function isn't improving after we remove the suspected offending agent. So, essentially, if stopping the drug or toxin doesn't lead to recovery, or if the diagnosis is uncertain, a biopsy provides definitive evidence. This step helps us ensure we're managing the patient correctly and guides further treatment decisions. It ties into our overall theme of accurately diagnosing and effectively managing renal issues. All right, let's look at this scenario carefully. We have a patient with biopsy-proven acute interstitial nephritis, or AIN, who hasn't shown any renal recovery after 7 days of stopping the offending drug. This is an important point because it suggests that the initial management might need to be reconsidered. Now, considering the options, the key question is, what's the best next step in this situation? Should we continue observation, or is it time to escalate treatment? Starting an ACE inhibitor, corticosteroids, or initiating dialysis are all potential options, but each has its own implications. In this context, since there's no improvement after a week, continuing observation alone might not be sufficient. The evidence suggests that corticosteroids could be beneficial here, as they can help reduce inflammation and promote recovery of kidney function. It's also important to note that dialysis would be reserved for cases where the patient develops severe renal failure and is symptomatic or volume overloaded. So, the most appropriate next step at this point would be to start corticosteroids to address the persistent inflammation. This aligns with current management strategies for AIN that isn't resolving after drug withdrawal. Remember, the overarching goal here is to prevent further renal damage and support recovery, so timely intervention with corticosteroids can be crucial in these cases. The correct answer here is C now. Let's unpack why that's the case. Early corticosteroid therapy, ideally within the first 1 to 2 weeks, has been shown to improve renal recovery in cases of acute interstitial nephritis, or AIN. This is especially true if there's no improvement after simply withdrawing the offending drug. The key point is that timing is crucial. Initiating steroids early can make a real difference in patient outcomes. So, while stopping the causative medication is the first step, adding corticosteroids promptly if the kidney function doesn't start to improve can really help in the recovery process. This approach highlights the importance of early intervention in managing AIN effectively. All right, let's look at this case. We have a patient who has been using analgesics long-term and has developed chronic kidney disease, or CKD. The key features here are small kidneys and sterile pyuria, which means white blood cells in the urine without bacteria. Now, considering these details, the most likely diagnosis is analgesic nephropathy, which is best categorized under chronic interstitial nephritis. This condition results from prolonged use of painkillers, especially combinations that contain phenacetin, acetaminophen, or NSAIDs. It often causes small, shrunken kidneys, and sterile pyuria is a common finding because the inflammation affects the interstitial tissue without causing infection. This example underscores an important concept in our presentation: how chronic medication use can lead to specific patterns of kidney damage. Recognizing these patterns helps us differentiate between various causes of CKD. So, when faced with small kidneys and sterile pyuria in a patient with a history of long-term analgesic use, chronic interstitial nephritis, or analgesic nephropathy, becomes the most probable diagnosis. The correct answer here is B now. Let's talk through why that is. Chronic exposure to analgesics, meaning long-term repeated use, can actually cause a condition called chronic interstitial nephritis. This is a type of kidney damage that affects the tissue between the kidney tubules. Over time, this damage can lead to a progressive decline in kidney function, which is known as chronic kidney disease or CKD. This is an important concept because it highlights how certain medications, when used excessively or over long periods, can be harmful to the kidneys. It ties into our overall theme of understanding drug-induced kidney issues and emphasizes the importance of monitoring and cautious use of analgesics. So, recognizing this link helps us better prevent and manage chronic kidney problems related to medication use. Let's take a closer look at tubulointerstitial nephritis, or TIN. This condition primarily affects the renal interstitium and the tubules, which are essential parts of the kidney's filtering system. When these areas are inflamed or damaged, it can lead to significant issues like acute kidney injury, or AKI, and even progress to chronic kidney disease, CKD. One of the most common causes of this inflammation is drug-induced acute interstitial nephritis, which is actually the most frequent form of acute interstitial nephritis we see in clinical practice. Recognizing this connection is important because many drugs can trigger this immune response, leading to inflammation and impaired kidney function. So, understanding how TIN develops and its causes helps us better identify and manage these cases early, ultimately protecting kidney health and preventing long-term damage. Now, let's take a look at some of the common causes of kidney issues. First up, drugs. Certain medications like proton pump inhibitors, or PPIs, are widely used for acid suppression, but they can sometimes contribute to kidney problems. Antibiotics, especially beta-lactams, are another culprit. And we can't forget NSAIDs, which are common pain relievers. Long-term use of these can also impact kidney health. Moving on, infections can also be a significant cause. Various bacterial or viral infections can directly damage the kidneys or trigger immune responses that harm renal tissue. Autoimmune diseases are another key factor. For example, Sjogren's syndrome, which primarily affects moisture-producing glands, can also involve the kidneys, leading to inflammation and damage. Toxins are also important to consider. Certain substances, like analgesic nephropathy caused by overuse of painkillers, can lead to kidney injury over time. Lastly, tubulointerstitial nephritis is a specific type of kidney inflammation that affects the tubules and interstitial tissue. It can be caused by drugs, infections, or autoimmune processes, and understanding these causes helps us better diagnose and manage kidney-related conditions. Overall, recognizing these common causes helps us take a proactive approach in prevention and treatment of kidney issues. Let's talk about the clinical features of this condition. One key aspect is AKI, or acute kidney injury, which often presents with a bland urine sediment. That means when we look at the urine under the microscope, there are no significant abnormalities like red or white cell casts, making it somewhat tricky to identify solely through urine analysis. Now, a classic triad to keep in mind includes fever, rash, and eosinophilia. However, it's important to note that this triad is often incomplete, so not all patients will display all three features simultaneously. Another important point is sterile pyuria, which refers to the presence of white blood cells in the urine without bacterial growth. Along with that, white cell casts can sometimes be seen, indicating inflammation within the tubules of the kidneys. All of these features point towards tubulointerstitial nephritis, which is an inflammation affecting both the tubules and the surrounding interstitial tissue of the kidney. Recognizing these clinical signs helps us piece together the diagnosis and understand the underlying pathology. Let's talk about how we approach diagnosing tubulointerstitial nephritis. First, clinical suspicion plays a crucial role, so, considering the patient's symptoms and history, it's important to pay close attention to their drug history, since many cases are drug-induced. Next, urinalysis is an essential step, especially looking for white blood cell casts, which can indicate inflammation in the tubules. If the diagnosis remains uncertain, or if the condition isn't improving with initial management, a renal biopsy becomes necessary. This helps us confirm the diagnosis and rule out other causes. Remember, identifying tubulointerstitial nephritis early is vital for effective treatment and preventing further kidney damage. Let's talk about management strategies for tubulointerstitial nephritis. First, it's crucial to stop the offending agent, whether it's a medication or another harmful substance. This step helps prevent further kidney damage. Supportive care is also vital. Ensuring the patient stays well hydrated and maintaining electrolyte balance can make a significant difference. If there's no improvement, early use of corticosteroids can be considered, as they help reduce inflammation in the kidneys. In cases of severe acute kidney injury, dialysis might be necessary to support kidney function until recovery occurs. Overall, recognizing and managing tubulointerstitial nephritis promptly is key to preventing long-term damage and improving patient outcomes. Let's go through some key pearls about tubulointerstitial nephritis. First, PPI, or proton pump inhibitors, are a common modern cause of acute interstitial nephritis, or AIN. It's important to keep that in mind when evaluating patients with unexplained kidney issues. Next, eosinophils can be a helpful clue. They're suggestive of AIN, but not diagnostic on their own. So, seeing eosinophils supports the diagnosis, but it doesn't confirm it definitively. Moving on, white cell casts in the urine are often associated with kidney inflammation, but they don't necessarily mean glomerulonephritis. This is a common misconception, so we need to interpret them carefully in the context of other findings. Another critical point is that early treatment with steroids can significantly improve outcomes. Initiating steroids promptly can help reduce inflammation and prevent long-term damage. Finally, delaying treatment can lead to fibrosis and chronic kidney disease, so timing really is everything. Recognizing and managing AIN early can make a big difference in preserving kidney function. Overall, these pearls highlight the importance of understanding the causes, signs, and timely management of tubulointerstitial nephritis to prevent irreversible damage. Thank you so much for your attention today. I really appreciate the time you've taken to explore these ideas with me. As we've seen, understanding these concepts is crucial for our overall success. Remember, the key points we've covered, from the main strategies to the practical applications, all tie back to the larger goal of continuous improvement. I hope this session has provided you with valuable insights and inspiration to move forward confidently. Again, thank you for being such an engaged audience.